Insightful and thought-provoking keynote to the future of our profession. We have certainly given us much to ponder. We would now like to move to another session. We can now, if our speaker is ready, we now transition from broader future to the specific and pressing challenge in global eye care. We need to move for a specific issue, which is myopia. Myopia is not just refractive error. It is a public health priority with rising prevalence worldwide. This brings us to our next dedicated session, which is Mastering Optometry Practice for Myopia Management. The session designed to move from awareness to actionable expertise. We will explore the latest evidence, clinical strategies, and practical tools essential for modern myopia control. Our first keynote speaker for this session is Dr. Carla Lanca, is a research associate at New York University, Abu Dhabi, trained as orthoptist and specialized in myopia epidemiology, environmental risk factors, and clinical intervention for myopia control. She collaborates with international research teams and has authored multiple peer-reviewed publications. Dr. Lanca is a regular speaker at scientific meetings and is committed to advancing research and education in eye health. She will speak about atropine for myopia control, exploring doses, response, and ethnic variability. Welcome, Dr. Carla.
Thank you very much. Can you see my presentation and hear the sound well?
Yes, yes.
Yeah. So first of all, I would like to thank the invitation to the Sudanese Optometry Society. I would like to congratulate you all for this event. And I also want to welcome everyone, all the attendees, and also to congratulate for the program and the excellent speakers. So today I'm going to speak about atropine for myopia control. I've seen that there are a few questions about atropine in the chat, and we can later discuss more about this topic. Today, I'm going to focus on our research, and what we have been looking into atropine is essentially dose response, but also we are very interested in looking into ethnic variability. So this is just my conflict of interest, which are not related with the present conference. So as a background, let's talk a little bit of myopia. So first, we know that myopia has reached pandemic levels, especially among children. And the levels of myopia and the prevalence, we know it's much higher in East Asia. Nevertheless, we have seen many reports describing and projecting increases all over the world. More important is when we are looking into the levels of myopia. And we know that when children and adults progress into their myopia and reach high myopic levels, which is usually -5 to -6, depending on some of the definitions, there will be associated sight-threatening complications. And some of them have been described before. For example, retinal detachment, glaucoma, but also myopic maculopathy. So very recently, we published this review in the Journal of Progress in Retinal and Eye Research. And we looked into several factors connected with myopia, and especially the overall prevalence of myopic maculopathy. And as you can see here from the graphs, the countries that are more affected, I mean, Singapore, Japan, and China. But more important than thinking only about high myopes, we know that no level of myopia is safe, and even lower levels of myopia can lead to some of those complications. So there are several interventions to treat myopia, but today I'm going to focus specifically on atropine. So we know that it's a non-selective muscarine antagonist. It's used to slow down myopia progression. So as we know, also there are several concentrations that can be used, but mostly if we looked into what have been done in different countries, low dose formulations are the ones that are widely adopted. And the reason why we usually use low dose formulations is because they help us to reduce the side effects while still reducing the progression of myopia. So the most common use are 0.1 and 0.5. 0.01 and 0.05, sorry. When we look into the results of the studies that have been published, however, we still have some uncertainties connected with the treatment. Also, we still have some questions about the optimal concentration, but also the duration of treatment. So how long should we treat a child? And also if there are any differences in efficacy when we are looking into different populations, for example, Asians versus non-Asian populations. So if we looked into what have been done before in terms of looking into those types of populations, we know from studies from Bullimore and Brennan, as you see in this graph, that shows annual axial elongation in millimeters according to age. We can see the differences between Asians and non-Asians. And as you can see from those studies, this is just one example, the mean axial elongation is 38% greater in Asians compared with non-Asians. From this study that was published by this group, they also found that although there is higher elongation in Asians, both of the groups, they decline about 50% per year with age. And another thing that is important to note is that they also reported that prediction intervals show substantial variability, which means that we need to be careful. There are some variability in terms of what we are seeing in the results. So we now know that 0.01 and 0.05 are widespread in clinical use, and have been many publications have been published in Asian populations. So from the studies that we have now, I think most of the systematic reviews show that atropine seems to be reducing and seems to be effective in controlling myopia progression, but the studies are of short-term duration, and they are mainly focused in Asian cohorts. We also have some new data that has been published in these recent years. So studies from non-Asian cohorts, like the PEDIC from the USA. We also have the WATAM Australia, the Mosaic and Sham. And it's interesting to see when they were treating those children, they found modest or some no benefit in Western children. Nevertheless, we know from the studies from LAMP, which are very well known from Hong Kong, that stronger efficacy is achieved if we use 0.05. But this, of course, it's mainly focused on Asian children again. And how about studies showing different effect sizes? Is there anything? So we were able to find an old paper. This is from 2014. At the time, the authors looked into these two types of population. And as you can see, when we look into the results, the effect sizes were higher, so more efficacy in Asian children compared with Caucasian children. But at the time, as you can see from the dosage that were here, the studies were published at the time with higher doses. So we really wanted to understand if this effect persists when we are looking into low dose atropine. We also wanted to understand if there is any difference in terms of other interventions for myopia. So we looked for several studies, and there's not much information in terms of differences in efficacy in different populations, but we found these two studies. So as you can see here from these two studies, they use optical interventions, and they are multi-country trials. So the first one that I want to show is these 3-year randomized clinical trials of MySight lenses. So this study, they recruited patients from Canada, England, Portugal, and Singapore, and about 55% were white and 24% were East Asians, and mainly Singaporean and Chinese. So when they were looking into the interaction effect between the investigational site and myopia, they didn't find any differences. So another study that is interesting to see, it's the randomized clinical trial, soft contact lenses with novel ring focus. So they also recruited children from different sites. So in this case, it was from Canada, from China, and from the USA. And about the same percentage of Chinese, 50%, no, sorry, a bit higher, 50% Chinese, 43% white children. And below 10% were East Asian in North America. So although they found that axial elongation and myopia progression were faster in East Asian, they didn't find a race by lens type interaction. So at the time when we were looking into this data, we found that for optical interventions, in the case of those 2 studies, there was no difference in terms of treatment effect, and we had the older systematic review show differences in atropine only. So we found that there is a research gap, and we should study more about this gap. So we wanted to really understand if there are ethnic differences. So we ran a study to evaluate dose dependence efficacy in atropine, and we compared the outcomes between 3 groups. So we divided the groups into East Asian, South Asian, and white European children. So the study was conducted and was already published. It was published in November, so very recent publication in the British Journal of Ophthalmology, which I invite all to read if you are interested in this topic. And the photos that you see here are from the co-authors that helped to put this study together. So what we did was we conducted a systematic review and also a meta-analysis. We looked into 34 studies. They were all RCTs, so randomized controlled trials. So we had data for almost 8,000 children with age below 16 years. And we only included studies that had at least 1 year of follow-up of these children. And then we looked into the outcomes of our study. So the spherical equivalent in diopters per year, but we also want to know the actual length in millimeters per year. And also we did conduct analysis by atropine concentration and also by ethnicity. So we divided the doses to make the analysis easier to understand. So we had 3 groups, the low, the moderate dose and high, which was 0.1%, then from 0.1 to 0.5, and then above 0.5%. We also divided the groups. So we had 5,000 over in East Asian, less in European children, almost 2,000, and 337 South Asian. And the follow-up of the studies differ, but it was between 12 months and 60 months. So we first looked into cell progression reduction. So in all these 3 doses, so what we were able to see, and what we already know, is that there was a dose-dependent efficacy, so stronger effect with stronger dose, and the same was also seen in the actual elongation. We also wanted to understand, because as I said in the beginning, we wanted to understand how about for low dose specifically. So the graphs that you see now here appearing in orange color are specifically only for the low dose, 0.1 and below. So as you can see here, we have 3 groups, and you can see that the effect was stronger for East Asian, then South Asian, and at the end, the white Europeans with the least effect. And when we looked into the actual elongation, we see the same pattern. So stronger effect in East Asian compared to the white European and the South Asian in the middle. We also wanted to understand the reasons behind this difference in effect. So we also collect data from pupil size to try to understand if the pupil size was similar or difference between these populations. So as you can see here from this graph, which is also very interesting to me, is that under the low dose atropine, when we are looking into the East Asian children, they have the greatest pupil dilatation. And this happens in the two conditions, pupil dilatation under photopic and mesopic conditions. However, when we are looking into the other two groups, we can see that they have smaller or non-significant changes. So even when we look in the pupil size, there is something suggesting that there might be something related with ethnicity and some variability in terms of the pharmacological response to atropine. I think there was a question also about adverse events. So we've also wanted to know how adverse events may affect treatment. So you can see here from the graph, when we analyze the adverse events, we found that East Asian had higher risk ratios compared to white Europeans. We don't have the South Asians in the graph because they were not reported in the papers that we included for this study. And regarding adverse events, we looked into all the adverse events, but one of the most interesting was photophobia, as you can see here below. So photophobia was higher in East Asian, so they complain more of photophobia than the white Europeans. And we also look into correlation between adverse events and atropine dose, and we did not find a correlation at this point with our data. So we've seen these results, and now is the time to think about why are we finding difference in terms of treatment effect. I don't have a definite answer at this moment, but there are some of hypotheses that can explain what we are seeing. One of them could be genetics. That could be some variability in terms of the pharmacological response to atropine. There can be some differences in terms of receptor sensitivity or metabolism, but also it could be environmental contexts. So we did a lot of analysis to try to understand, for example, when we take Asian children that are not living in Asia, but living in non-Asian countries, if the pattern is different, but we found that the pattern is similar, but we were thinking that maybe near work or time or education may modulate the effect size. We also looked into behavioral factors. So as you can see, pupil size was also different. So we were thinking if this is a response to the pharmacological response, but also it could be adherence to treatment. It could also be the installation technique, but also the formulation of atropine. As we know, the atropine is prepared in pharmacies, and there is a very interesting study from Mark Bollimore saying that some of the preparations are not prepared properly, and they may differ in terms of effect when they are instilled or if they are not stored properly, for example. But it could also be behavioral because it's difficult to assess if there are co-interventions. For example, we usually don't have information on these children to understand that while they were using atropine, if they were also implementing lifestyle changes, and I'm sure some implemented and others may have not done it. And it can also be that there are some interactions between gene and environment, and this, of course, needs to be further studied. There are also other factors that we need to take in consideration when we are looking into our data. So one of the problems that we found was that our analysis, as almost all analyses, have some limitations. So the most important limitation is that when we are looking into these studies, there is an ethic imbalance. And why is this? Because most trials were conducted in East Asia. And it's not only for atropine. If we are looking into myopia control treatments, we will see that many trials were conducted in Asia. So when we are looking into the data, it's difficult to generalize to other populations. Other problems are related with dose heterogeneity. So different studies use different dosage. And in Western cohorts, it's more often seen that they use 0.01%, while now in Asian cohorts, we are shifting to more use of low dose, but from 0.01 to 0.05. It could also be that we are seeing these differences because baseline progression are different. So white children, we know that they progress more slowly. So this may be the reason why we see smaller absolute effect sizes. It's also important to understand that we have a gap in terms of the duration of the randomized control trials. They are usually limited to 1 to 2 years, and we don't have data from long-term efficacy apart from the studies from Atlas in Singapore. And also the study variability. So we have seen for some of these analyses very high heterogeneity, and we don't know exactly the reasons why, but it could be because baseline myopia is different, outdoor exposure patterns may be different, but also adherence and outcome measures. And as I study more the topic of myopia, and especially with the studies that we have been conducted with other myopia control techniques or methods, I think one of the aspects that need further study is adherence. So we need to understand, well, when a myopia control lenses, for example, is not working, we have to understand if it's the lenses, it's the treatment, or it's the adherence, because as it was spoken already here, awareness is very important. So if the parents are not aware of what they should do, and the child doesn't comply with the treatment, then of course we will not see a treatment effect. So it's very important to speak with the parents and to explain well what we want them to do, not only to adhere to the treatment, but explain well what could happen if myopia develops and leads to sight-threatening complications. And also, it is also important to explain them that myopia is a chronic condition. We don't have a cure for the disease. We have treatments that can lead to a decrease in progression, but we need to take care of the sight-threatening conditions and avoid high myopia. So almost coming to the end of my presentation, a few things that I want to say. So I want to highlight that we need to do further studies to understand if the difference that we are seeing are biological or methodological artifacts. We still have limited sample sizes and sometimes inconsistent subgroup analysis. So for future research, I think we need essentially more collaboration. So we need more data from different types of populations. So we need more diverse and global clinical trials that can include information, not only as we spoken here today from developed nations, but also from the others to have more data to be able to offer personalized treatment. But we also need to take care in consideration on these studies. They need to be stratified by ethnicity, age, and environment for us to have more information to treat. And of course, it is important to have gene and environment treatment studies. So just to finish my presentation, some of my take-home messages. So we know that there are differences between Asian and non-Asian in prevalence and progression. From our study, it seems that atropine is stronger in Asian. When we are looking into optical treatments, they look less ethnic dependent. But of course, we need more studies, more generalized guidelines. And if we really want to advance to personalize myopia management, we need to integrate all of this information. And I think this will be the next frontier of precision eye care, and we can only do it if we collaborate all together, different nations, different countries, to get the answers that we need